What's up, guys? Welcome back to From the Ground Up. Today, we're going to get right into it. I want to touch on something that has kind of been ruminating in my brain since I posted a reel last week, and just kind of the subsequent fallout, all good fallout, but you know, what has transpired since then in my brain. And what that is this idea that you truly cannot treat what you don't understand, right? And understanding goes beyond just what your eyeballs can see. And, you know, what I mean by that basically is like clinical strategy has to include movement. Yes, like looking at the patient's movement, but it also must include this integration of the patient's story, the patient's symptoms, and the patient's goals, right? And so the backstory on kind of what got me into this, you know, big idea of you can't treat what you don't understand, even if it's right before your eyes, right? Is what we see right before our eyes is not the whole story. So last week I posted a reel because I'm always like just filming B-roll footage whenever I'm doing my workouts because it makes really good B-roll content for explaining movement patterns and things like that. And so this particular video I was filming just me doing front loaded squats, right? And I noticed as I was watching back the video of myself, I was like, every time I stand up out of the squat, my right toes pop up. And I just, I threw that up in a reel and I just kind of asked the question. I asked the class, I was like, do you guys see my right toes popping up? What are y'all's theories on what might be happening? And that reel got a lot of engagement. And I think just because people like, assessing movement and assessing biomechanics, right? That's the fun part. That's kind of the sexy part, if you will, is being able to call out what you see with your eyes and then show your skill of like what that might mean. And like I got a bunch of responses from people. They pointed out, yes, my toes were lifting. Also, my right heel on the way down was raising up. So, if you imagine a squat video from the side, at the depth of the squat, my right heel ever so slightly just kind of like lifted off the ground. And then as I pushed back up to stand and kind of reascended, pretty much in like the top half of the ascension, those right toes then would just pick up off the floor as I kind of like came to standing. And so, people in the comments were saying like stiff foot and ankle, or the big toe is not grounded with the floor, or your hip range of motion isn't adequate, or your hip control isn't adequate. Your hip is weak. Your glute is weak. You're avoiding your right leg. Your right pelvic floor is tight and tense and not allowing you to move properly, and there were some other things about your shoes suck or whatever. And I'm like, whoa, don't come at my shoes, first of all, because I was doing squats in my running shoes, okay, which I understand is not the recommendation, but my running shoes, quote unquote, I say quote unquote because I'm not a runner, are from Ultra, and they are 0 drop wide toe box, minimal. And so the reason I sometimes do lift in them, this is a side note, is that I am training for high rocks. And so sometimes I'm incorporating like treadmills, sprints, or runs in the middle of my workouts, right? And so it just feels better on my feet. So I understand I'm not supposed to squat and lift weights in running shoes, but these are different than your traditional running shoes, people. Okay. But don't come at my shoes and my feet. Just kidding, you can. But so that's kind of the gist of what everyone was saying, was this stiff foot and ankle, stiff hip, weak glute, tight pelvic floor, bad shoes. And those were the majority of the comments and kind of the assumptions that people were making, again, simply from what they could see. Because I literally just threw the reel up and I said, why do y'all think this is happening? No context. So that got me thinking, I found myself wanting to reply and share like my story with them of why they see a stiff ankle and a stiff foot and a weak hip or whatever it is. And that made me realize, like, when we're observing our patients' movement patterns, like we better have done a really good job before we start looking at them, or before we start intervening for sure, on hearing their story, right? Because my story has tons of context that might confirm a lot of the stuff that people are seeing, but probably would help them have, even more answers around the why behind my movement pattern. And what my story in this particular instance is let's see, this is 12 years ago now almost. I had a crush injury to my right knee. And I was in PT school, actually. We were in lab. And what we did in lab was we used like the high low tables were kind of like our desks. That way we could sit there and have some lecture time and hear the lecture and then pause and practice whatever it was that the lecture was over, whatever skill we were learning, whatever it is, right? So we would sit, stand and practice, sit, stand and practice. So like the high-low tables, the mechanical tables essentially were our desks. And so what happened was the table that I was sitting at malfunctioned in some way and started lowering towards mine and my partner's legs that were just, tucked under there as it was a desk. And I, if you don't know this about me, I am 6 feet tall. I have really long legs. And so the table hit my legs before they hit her legs. She is of average height. And so naturally my knee was higher than hers. And so the table actually clamped down on my right knee and knocked me out of my chair because it continued to lower and kind of crushed down on my knee. And it's kind of hard to describe without showing a picture. And I've actually shared this story. I've shared pictures on my social media multiple times. So feel free to go, search and find those photos. But it knocked me out of the chair and I ended up on the floor on my back with my right leg bent in full knee flexion and full dorsiflexion, and the table coming down on top of my knee, and there was another bar that had like slid underneath my toes, forcing me into this like dorsiflexion position. And so if you can imagine, like the table is trying to basically snap my tibia in half, basically with the pressure. It's like those hydraulic videos that you see, like, or maybe they're on my algorithm where I'm scrolling through reels and it's like the hydraulic thing coming to crush random objects. I don't know. That's weird. But sometimes I see those and I'm like, oh yeah, that like almost happened to my tibia. It's fine. So luckily I had a quick thinking student in my class. He had run over and unplugged the table because it just was continuing to try and crush my tibia. He unplugged it, so it stopped. But, everyone always asks me, well, why couldn't you just move the table? And it's because my foot had gotten on top of a bar. So like I had a bar under my toes, like the ball of my foot, and then on top of my knee was the table itself. So you couldn't just lift it up because there was something under my foot and they were kind of like smushing it like a sandwich, basically. Hard to explain. I've shared photos before, so there's that. Go search for it. But that, like, I was stuck there for over an hour. My classmates, my professors tried to get me out, of course, and we didn't realize the extent of how stuck I was probably until 20 or 30 minutes in. People, we tried to cut off my shoe and just kind of wiggle my like foot off that bottom bar. What we didn't know was that the part that was crushing my knee, I actually had a pole about the width of like a finger punctured into my lateral knee joint. And so like right at the joint line, basically. And so any little wiggle of the table, that pole that was in my knee joint was wiggling and causing horrible excruciating pain. So every time they would try and like rotate my foot to try and wiggle my foot off of the bar underneath it, I was like screaming bloody murder. And I think at first people just thought I was only panicking, which like valid to panic, right? I'm trapped in this thing. But none of us, myself included, like I couldn't articulate what I was feeling. I just knew that it was not good. And so finally, 20 or 30 minutes in, when I think people realize like, oh, like this is like, we can't get this girl out of this thing. So they call 911, the firefighters come. I remember one of my classmates, my best friend, basically in PT school, she was like, the firefighters are coming and Philip's on his way. And Philip's my husband, and I just couldn't fathom. I was like, no, he's not. Philip's playing tennis today. And I know that because it was Good Friday. So he was off work and our family was in town. He was playing tennis with his dad. It was just funny. I remember being like, no, he's not. He's playing tennis. And she's like, yes, he's on his way. I don't know. I was just not in my right mind, y'all. So Philip shows up, firefighters show up. I'm like, my heroes. And they ended up using the jaws of life to get me out because they also tried to like fiddle. Well, can we unscrew this? Can we unscrew that? They ended up getting like the top pad part unscrewed of the table. And so once they did that, they could actually see what was actually crushing my knee. And I had 3 points crushing my knee. I had that lateral puncture wound causing that puncture and pressure. I had a bar across basically my distal femur, like right above my knee, right on top of my quad. And then I had on the medial aspect of my knee, another bar just kind of like pressing. So it kind of was creating this triangle where like from all 3 points was just coming down on my knee. And so once they got that top part off, that's when they were like, oh, like we gotta cut this girl out. So jaws of life, just like you would see in the movies, cut through the table. They dismantled it piece by piece. It was so loud if you've never heard one of those things. By now, I'm just in an alternate universe. Also, they couldn't give me any medication. Apparently, if you're trapped somewhere, whether it's a vehicle or a rogue high-low table, you can't have medication in case you have a reaction. So I couldn't have pain meds, anxiety meds, anything because I was still trapped. And so one of my sweet classmates was sitting next to me, like, and of course my husband's right there too. And she's like trying to lead me through breathing exercises. And, back then I didn't believe in breathing exercises. Like I thought it was all too woo-woo. And I'm just like, stop telling me to breathe. But it's just wild to look back. So that's the context of this right knee injury. They freed me, put me on the stretcher, drove me to the emergency room. We thought I was going to need emergency surgery to clean out the joint capsule. They did a little test in the ER where they inject the joint with fluid to see if it comes out the other side of the puncture. And that would essentially tell them that the joint capsule itself was punctured, which is high risk of infection, which that's what would require the surgery. Not even thinking about like any bone or ligament damage at this point. This was strictly like, are we going to need to go do a surgery to clean out the joint? Well, the test that they did was actually negative, which was huge. So the pull had punctured like through the skin and, some tissue out there, but didn't get all the way into the joint capsule. So yay, hooray. Didn't need emergency surgery that day. Got some fun medication, went home, did PT extensively for, I don't know, I want to say months. It was months of PT because like my quad shut off and all the things. My quad was actually torn. I had extensive bone bruising in the knee. Because the ankle was in such extreme dorsiflexion under so much pressure for over an hour, I had bone bruising down there in the ankle joint. And so, yeah, it's a pretty big trauma to my right lower extremity, you guys. And since then, my ankle and my knee joint have just really never been the same. Tons of, short-term inflammation in there, which led to changes in my movement patterns and range of motion things and all the things. And like, I'm totally functional and I'm not in quote unquote chronic pain, but like, I have like right knee pain and my ankle on my right side, despite me probably doing ankle mobs and midfoot mobs like 3 to 4 times a week, like for years and years and years of my life, like it's still stiff as a brick. And so knowing that context, which you did not know when you saw this reel, probably would have had you thinking, maybe some of the same things that you saw, but it gives you this context of like why it's happening and maybe like what's kind of the underlying root cause. Because again, like a lot of people were saying, well, it's the hip or the pelvis is lacking range of motion or strength. And that's why we're seeing this down at the foot and the toes lifting up. And then other people were saying, well, no, it's a stiff ankle and that's why we're seeing the toes lifting up. And so it's this idea of knowing the patient's history and then being able, having that trained eye to see what you see in their movement patterns, knowing what their current symptoms are, which if I was your patient and you asked me, like, currently I don't have a ton of symptoms, I would probably say, well, sometimes I have right knee pain, not usually though. Sometimes, more often than my knee, I'll have kind of like right lateral hip pinching pain, especially at like the bottom of a squat, but it doesn't stop me from working out or lifting heavy or running or whatever it is. I do have, a right SI joint that will tend to flare up, especially, whenever I progress my strength programs, new moves, lift heavier, more reps, whatever it is. Usually, whenever I make a significant change on any of those variables, I'll feel it in my right SI for, a few days to a week, and then it'll adjust and calm back down. And, just some like general right sided, dull, aching, sciatica type pain on and off. And so, like, those are kind of my symptoms that don't really prohibit me from living my best life. But, if you're my PT and ask me that, that's probably what I would mention. And what you should also ask me is, what are my goals? Because at any given time it could change. Like right now, I would say, well, if I'm, your patient and you're doing this movement assessment on me, I would say, well, I'm currently training for a high rocks in a few months, and I want to be able to go all out at this high rocks, and I would love for it not to piss off my SI joint for the next week or two afterwards, right? And so that's my goal. And so knowing my history, knowing any of my current symptoms, and knowing my goal, those three things paired with what you are trained to see in the biomechanics and the movement patterns when you're watching someone move, you have to be able to put all those pieces together, and that is what will drive your intervention. Because if you just see the video, someone's going to tell me to go do ankle mobs, and I'm going to be like, sis, I've been doing that for 5 years, multiple times a week. Someone else is going to say, oh, you need to strengthen your glute med. And I'm going to be like, literally, no, I don't. Like, come test my glute med. Like, I have very strong glutes. Like, that's not it. So it's like you have to have all these other strategies and frameworks of thinking when you are choosing what intervention to do with your patients, right? And, you have to align your treatment plan with what is going to get them to their goal the fastest. Okay. And you don't know that unless you ask them what their goals are. You know what their goals are. And I can't tell you how many patients have told me, no one has asked me these types of questions. And in my head, I'm like, no one cares why you're coming to pelvic floor therapy. Like, no one cares what you want to get out of being here. And these are patients who, tried other places or whatever. And they're just like, no, I just show up and they give me the pelvic floor exercises. And I'm just like, y'all, it's literally simple. You just ask the people what they want. Why are you here? Why are you here? And where do you want me to help you get to? Right. And it's such an underrated, simple skill. And, that brings me to, if I was my own patient, what would I assess? If I was my own patient and I had told myself that story, and then I listed off my current symptoms, and I told myself, and my goal is high rocks without flaring up my SI joint, right? What am I going to look at if I see that squat? Well, if I want to know what is the main driver of that toe lift off and of that heel, I want to look at things like, yeah, let's check the dorsiflexion range motion, right? Let's check it to see if that's the reason for that weird kind of movement pattern that I'm seeing. And so, I'll compare side to side. I would, check passive dorsiflexion, but really I want to see kind of the patient in that active loaded dorsiflexion, knee drive to wall. I also, want to check midfoot mobility, because if the midfoot doesn't have range of motion to go into that pronation, then the ankle can't go into dorsiflexion anyway. So it might look like a stiff ankle, but it might really be that the midfoot's not pronating, which is not allowing the ankle to dorsiflex. So I would look at that. I would make sure I had adequate midfoot pronation range of motion, right? I would want to look at big toe. Do I have enough big toe extension range of motion? Am I overly gripping my big toe? Am I trying so hard? Is my center of mass so far forward that my big toe is having to just grip constantly to keep myself from falling forward, right? So I would look at that. So all of those things are kind of ground up. What are we looking at from the ground up to see if is it a ground up cause for my toes lifting off the ground? Or I also want to see, do I have adequate hip and pelvis mobility and strength, right? So I'm looking at things I love a good Ober's test. And the way I use this test is more to assess for bony position of the ilium compared to femur range of motion in the socket, right? And so you do the Ober's test, and that can kind of tell you if that knee can't get down to the test table, and you're feeling kind of that bony block as you're testing it, it can usually indicate that the ilium is actually more anterior and externally rotated. And so you can do femoral mobilization or range of motion exercises all day long. But if you haven't fixed the position of the ilium first and created space in the acetabulum for the femur to go into internal and or external rotation, it's literally not going to matter. So knowing what position the ilium is super important. Knowing up at the rib cage, what is my breath strategy? Am I, breathing up and out, or am I able to breathe and expand into my back? That's going to tell me about my preferences and ability for my ribs to be able to internally rotate, right? And if that can't happen, that changes things down the chain. So that's more of like a top-down look at potential causes. All of those things are probably some of the big things that I'm looking at whenever I'm assessing if I was my own patient to try and figure out why is that squat like this, right? And it's just kind of differentiating the difference between ground up versus top down issues. And you don't know what you don't know until you've learned all these tests and assessment to do. So that's kind of the way I would approach it is I would, after I've heard the patient's story, right? And then after I know, okay, what symptoms are you currently experiencing and what goal do you have to get out of being here with me, short term and long term, then I'm going to do all of my nice objective assessments according to those things that I've, gathered from the patient. And I'm kind of have my working hypothesis going in my head. All of those put together, then I'm going to say, okay, in my head, I'm like, here's what I've seen in the objective assessments and tests that I've done. She's telling me these things. Her goal is high rocks with no SI joint flare. So knowing that, here's where I'm going to start. I'm going to find, according to all of my tests and things, what is like the flashingly obvious, lowest hanging fruit that I can start on today that is going to get us one step closer to her goal. And this is important because we can't just treat what we like to treat or what we're good at treating. You might be great at restoring ankle dorsiflexion. I don't know. And if that's not the main low-hanging fruit, the main driver, maybe it's a little stiff, but it's not like the low-hanging fruit and the main driver of what you found that day in the assessment. And you go to give an ankle manual technique and an exercise because you love treating the ankle and are really, really good at it. Might it help a little bit? Sure, but it's probably not going to get them to their goal faster, and it's probably not going to get their buy-in sooner in the process, which is invaluable, by the way, getting their buy-in sooner. And that's the power of really being able to kind of utilize this framework of this combination of patient story, patient's current symptoms, patient's goals, combined with what you're objectively seeing. And then you putting all that together and asking yourself, okay, knowing what I know, seeing what I see, knowing where my patient wants to get, what's the lowest hanging fruit that I could attack today? If I could only pick one thing, what is that one thing going to be that's going to get us closer to Becky being able to compete in the high rocks without an SI joint flare? And I don't know what that thing is because I'm not my own PT and I didn't do all those tests on myself. So I have my assumptions, but if anyone wants to, do a case study on me, feel free. Start in the place that matters most to the patient, right? Tackle the thing first that is going to get their buy-in because they're going to walk away saying, okay, she gets it. She knows where I want to get to and knows how to get me there. I already noticed improvements in my chief complaint, or, I'm already 2 steps closer to my main goal just based on this one thing that she did today. And that's the power of putting all those things together and knowing where to start. So hopefully, just kind of breaking this down further and giving you kind of that framework of clinical reasoning to think through and helping you kind of know it's more than the biomechanics. It's more than the trained eye. The objective assessments are so important, yes, but they literally mean nothing if you haven't gotten the right information from the patient as well, right? So hopefully that's helpful. If it is, I would love for you to share this episode. DM me, tell me what your favorite part was, because, I couldn't shake sharing this with you guys because, like, truly, if all we do is treat what we see, we're going to miss the chance to truly help our patients, especially in the long term. We're going to miss the chance to help them hit their goals, right? So, love it. Love all of this. I could nerd out on this stuff all day long. Please share. It means the world to me. This is how we get this stuff out to more people. This is how the show grows. And this is, I mean, honestly, this is how we change the game of pelvic health is by more and more people hearing this stuff, thinking this way, applying these things to their patients. This is how we do it, you guys. And I can't do it alone, right? We're better together. So would love for you guys to share. DM me, tell me your favorite part of the episode. And also, I have the spring cohort coming for my No Kegels course, which takes you deep into all of this stuff. It takes you deep into my line of reasoning and my framework for the whole body as it pertains to pelvic floor dysfunction, right? And it gives you these objective assessments to be doing and helps you pull this stuff out of patients so that way you know where to start and what to do and how to progress them through a plan of care. So be sure to add yourself to that wait list for this spring. It's going to be in March of 2026. So I'm super pumped about that. Thanks, you guys. I hope everyone has a great rest of your day and let's change the game.